Welcome. Today, we are diving deep into surgical endodontics. Let's be real, this topic can be a little intimidating, but it is absolutely crucial for clinical success. We're going to break down the entire process, from that first diagnostic puzzle to the final suture, and arm you with the clear, high-yield knowledge you need to ace your exams and master your craft. Ready? Let's get into it.
So, here's our game plan. First, we'll cover the basics, the why and when of surgery. Then we'll get into the really critical decision-making part. After that, we'll learn how to classify cases, design the perfect surgical flap for access, and walk through the core techniques you'll use. And of course, we'll wrap it all up with a rapid-fire review of everything you need to remember. So, what is surgical endodontics, really? You can think of it as our plan B. It's what we turn to when a standard root canal has failed, or maybe wasn't even possible to begin with. This is how we get direct, hands-on access to the outside of the root, so we can fix problems that are totally out of reach from inside the tooth.
And that brings us to one of the most important and most tested topics out there: knowing when to operate, making that call, knowing the indications, and just as critically, knowing the contraindications. Well, that's fundamental. Let's start with the green lights.
A lot of times, surgery becomes the go-to option when we've hit a clinical roadblock, right? This could be a stubborn abscess that you just have to drain, or a previous root canal that's failing no matter what you do. Other classic reasons, you've got calcific metamorphosis, where the canal has literally walled itself off with hard tissue, or it may be an infected horizontal fracture that's way down near the tip of the root.
The need for surgery can also come from, well, us. Procedural errors happen. A separated file, a perforation, and surgery can be the way to fix it. Other times, it's not our fault. The tooth's anatomy is just wild, with crazy curves or extra canals we can't get to. And finally, if you suspect something more serious and need a tissue sample for a biopsy, surgery is how you get it.
Okay, now for the red flags, the contraindications. And this is all about putting the patient first. If someone has a condition like uncontrolled diabetes, or they've just had a major surgery like a heart attack, the risks are just too high. The first trimester of pregnancy and any kind of bleeding disorder are also pretty much absolute no-goes. Beyond the patient's overall health, you've got to look at the tooth and its surroundings. A tooth with a super short root can't afford to lose any more length. Getting way too close for comfort to vital structures like the mandibular nerve or the maxillary sinus, that can make the procedure far too risky. And of course, if the tooth is non-restorable, has a vertical fracture, or has terrible periodontal support, surgery is just off the table. All right, so let's say we've decided surgery is the right move. The next step is to get organized. We need a system to classify the case. This helps us to find the problem with precision and map out our surgical plan, so we're not just going in blind.
Okay, lean in for this one, because this is one of the most important classification systems you will ever see: Rubinstein and Kim. You're absolutely going to see this on your exams. Class A is symptoms, but nothing on the x-ray. B, you see a small lesion. C, that lesion is getting bigger, extending up coronally. D is when you have a periodontal connection. E is a true combined endoperial lesion. And F, well, F is a total blowout, a complete perforation right through the bone.
Another way to slice this is to think about why we're doing the surgery. What's the goal? Is it just for surgical drainage to get some pus out? Is it periradicular surgery, like the classic apicoectomy? Is it corrective surgery to fix a mistake? Or are we talking about something bigger, like replacement or implant surgeries? This framework really helps organize your treatment options. And now we get to one of the most technique-sensitive, hands-on parts of the whole procedure: designing the surgical flap. The way you create this window to the surgical site directly impacts your visibility during the op, and, just as importantly, how well your patient heals afterward. Get this right, and everything is smoother. There are some non-negotiable, fundamental rules here. Rule number 1, and it's a big one: the base of your flap has to be wider than its free edge. Why? Blood supply. It's that simple. You also have to design it so that when you put it back, it's resting on solid, healthy bone. And you never, ever want to make your incisions right over the bony bulge of a root or an existing gum defect. That's just asking for healing problems.
So let's look at two of the most common designs, the triangular and the rectangular flaps. See the triangular flap here? It's got that one single vertical cut. It heals pretty well, but access can be a bit tight. Now compare that to the rectangular flap with its two vertical cuts. That design opens things up like you wouldn't believe, giving you amazing visibility, which is perfect for long roots or if you need to work on more than one tooth.
Okay, you might want to screenshot this slide. This is your go-to cheat sheet for flaps. Notice that for the posterior mandible, the triangular flap is often preferred to stay away from the mental foramen. But for a maxillary canine with its super long root, you're going to want the awesome access you get from a rectangular flap. Working on a tooth with a crown, the Ochsenbein-Luebke is great because it saves the gingiva. And the semilunar, honestly, you hardly ever see it anymore. The access is poor and the scarring can be pretty bad.
Okay, we've planned our attack, we've designed our flap. Now it's time to actually get in there and do the work. Let's walk through the key steps of the surgery itself, from making that first cut to sealing the root for good.
Let's talk about a simple incision and drainage. The whole goal here is to let the pus out. So after you get the patient numb, you make a horizontal cut at the lowest, squishiest point of the swelling. Then you go in with a blunt instrument to break up what are called loculations. Think of them like little walled-off pockets of infection. You got to break those walls down, and then you pop in a drain to keep things open so it can heal from the inside out.
Now here is an absolutely classic exam question and a real-life lifesaver in the clinic. How do you tell the difference between the root and the bone when you're in there? It comes down to color and texture. The root is yellowish, smooth, and hard. Bone is whiter, porous, and kind of granular. But here's the dead giveaway. The root won't bleed when you probe it. The bone will. Remember that.
For many of these surgeries, the main event is the apicoectomy. We are literally resecting the very tip of the root. But why exactly 3 millimeters? Well, that number isn't random. Decades of research show that removing that apical 3 millimeters gets rid of 98% of the apical ramifications and 93% of the lateral canals. That's where all the nasty bacteria love to hide.
And this right here, this is a total game changer. The angle of that cut, the bevel, is so important. The old school way was to make a steep, 45-degree bevel for better visibility, but we now know that's like opening up a superhighway for bacteria to leak out of all those exposed dental tubules. The standard of care today is a nearly flat 0 to 10-degree bevel. It dramatically reduces that leakage and is directly linked to much higher success rates.
Once that root tip is gone, we have to seal the end. You've got a few key materials to know: Super EBA, IRM, but the one you really need to know, the one that's kind of the gold standard right now, is MTA, Mineral Trioxide Aggregate. It's loved for its incredible sealing ability and because it's so biocompatible that it actually helps new bone grow.
And here it is, folks. This is the payoff. This is why we do all this work. You can see the big lesion before we started. Then, right after surgery, you can see the root end is resected and filled. But the real magic is the 12-month follow-up. Look at that incredible bone fill where the infection used to be. That is what success looks like.
Okay, deep breath. We have gone through a lot of ground today, so let's boil it all down to the absolute most critical, high-yield points that you need to have locked in for your exams.
All right, rapid fire review time. Number 1, you have to know your indications versus contraindications cold. Number 2, memorize the Rubenstein and Kim classes A through F. 3, for your flap, the base must be wider than the margin. Blood supply is king. 4, the magic number for an apicoectomy is removing the apical 3 millimeters. And 5, a 0 to 10-degree bevel is the modern standard of care. Got it? Good.
So we'll leave you with a question to chew on. Based on everything we just talked about, which specific flap design is usually the top choice for surgery in the posterior mandible, and what key anatomical factors make it the superior option in that tricky area? Think about it. Thanks for tuning in, and we'll catch you next time.